Hello, welcome to the Senior Rehab Project, the podcast for the community of rehab clinicians working to advance care for older adults. I'm your host, Nicole Nexon, and this is the State of the Sniff. Or, well, it would be. But instead today, we have a guest host, the awesome Meg Lowry. She's going to be exploring contemporary bone and muscle mass research with Dr. David Scott, PhD. You guys are really going to love this one, so check it out.
Hello friends, it's Meg Lowry here in a DownUnder Special. Today I'm going to be interviewing one of the great brains of the Twitter sphere, Dr. David Scott. He has interested me for such a long time. You've got someone in your Twitter feed who just posts really quality, high-value information about the most fascinating topics, and to me feels like he's just got such a wealth of knowledge that I wanted to pick his brain about, particularly around bone mineral density and falls risk and dynapenia and sarcopenia and frailty and sarcopenic obesity. So we're going to nerd out on the physiology and epidemiology side of things today. If you're happy to follow that train of thought with me, but before I introduce David, I just wanted to let you know, give you an update, because I know some of you have been following this in the Facebook group. I am back from Lebanon, and I just thought I'd let you know what that was about. So last year I was presenting at the World Physio Conference. I did this super informal presentation, like it wasn't even with PowerPoint. We were sitting on beanbags, and it was about how to approach developing an app. So WCPT asked me to apply to talk about that because of my experience with the Clock Yourself app. And anyway, so because I was talking about how I made Clock Yourself for the older adult population, and was explaining falls and balance and cognition and how all those things are related, there was a guy in the audience from Lebanon who was on the executive of their association, the Order of Lebanese Physical Therapists or Physiotherapists, who was interested in bringing me out to present at their conference, which I initially declined, and gave him the names of several esteemed colleagues who I thought would be a better fit for that purpose, because I'm by no means an academic. And then, look, for some reason, either they didn't accept or it wasn't followed up properly, but he came back to me the next year saying that the World Health Organization had sponsored them to nominate some clinicians or academics from around the world who they wanted to bring in to improve their professional development and upskill their physiotherapists on nominated areas of interest. And the Order of Physical Therapists of Lebanon this year was changing its structure. It was bringing in some smaller special interest groups that previously sat outside of the Order of Physical Therapists, and one of those special interest groups was peds and another was geriatrics. So they really wanted a geriatric workshop on exercise prescription for the older adult and assessment of the older adult. So I didn't say no twice, because it was a fully funded, a wonderful opportunity. So I just spent about 5 days in Lebanon, and they were just so enthusiastic about learning more about the older adult, and they were so enthusiastic about the workshop, and I did a keynote speech on falls and the evidence behind falls, and a little presentation on does ageism influence how we prescribe exercise to older adults. So I flew that flag. It's one of the pillars of the Senior Rehab Project, is to dismantle ageism. So I just thought I'd let you know that went really well, and I've since been asked to run the workshop in Egypt next year. So I'm just starting to organise that, and I'll return to Lebanon to run a longer workshop. So it's funny how these situations just come out of nowhere, and I just didn't want to say no to something that would help our colleagues in the Middle East improve their skill set and their knowledge, and help them to better engage with a a broader community that is the Senior Rehab Project. So we've probably had a bit of an influx of physiotherapists joining the Senior Rehab Project Facebook group this week from Lebanon, Jordan and Egypt. And so make sure you say hi to them and make them all feel welcome. I just thought that was just something worth sharing because it's a pretty cool thing that's just happened in my life. So there we go. I'm adjusting to the change in time zone again this morning. It's 7:15 and time to start talking about sarcopenia and falls and osteodynapenia with Dr. David Scott. David, welcome.
Hi, Meg. Thank you for having me.
Thank you for joining me at this hour. And David just shared with me that he has a 4-year-old daughter who he says can't be trusted. So, David, where are you sitting right now?
I'm sitting in my car in a very dark garage, but I'm quite sure we won't get interrupted.
I hope at least it's not too hot down there, right? You're not sweltering in your car, I should hope.
No, that's right. Melbourne is put on a chilly morning, so I'm actually quite comfortable in the car at the moment.
Wow, there you go. I'm from Melbourne originally, David. I don't know if I told you that, but I might have. I think
Yeah,
I showed you some photos of my mum in Melbourne just recently, who fell over and broke both of her arms and her nose. So we exchanged some comments around that one. So David, just give us a little bit about your background. You studied undergraduate sport and exercise science.
That's right. Yeah, so I'm actually from Tasmania originally. So grew up in Launceston in Tasmania. Went to the University of Tasmania at Launceston to do exercise and sports science as an undergraduate degree. Was lucky enough at the end of that to do well enough to be offered an honours project, which was, at that stage I just wanted to work with elite athletes. That was my dream. And it just happened with this honours project. The projects are really allocated to honours students. You don't really get to design and run your own projects. But I did get to work with elite triathletes, but we had both young and older triathletes. And what we were doing was looking at how do they recover from a eccentric exercise bout, which we know really shocks the muscles and creates a lot of muscle soreness post-exercise. So just through that honours project, I became really interested in how the young versus the older athletes, and by older they were just masters athletes mainly in their 40s and 50s, but I was really interested to understand why our muscles don't function as well as we get older, and why potentially they don't recover as well, or at least that was our hypothesis. But then we found that actually in these masters athletes that are exercising all the time, they actually recovered just as well as the young athletes. So I guess the result of all of that research in my honours year was I just had suddenly developed a real interest in ageing and muscle. And so I contacted Professor Graham Jones, who is a rheumatologist at the Menzies Institute in Hobart in Tasmania, because I knew he had a large cohort study called the Tasmanian Older Adult Cohort of older adults who had muscle function measures and muscle mass measures over long periods of time. And I just contacted him to ask if he'd be willing to supervise me for a PhD, and then if I was lucky enough to get a scholarship, which I did, that I could work on that study. And he was really supportive and interested in this new area of sarcopenia. And from there, moved down to Hobart and did my PhD in the area of sarcopenia.
Now, there are worse places you could be studying a PhD than Hobart, that's for sure. I was there 2 days before Lebanon, actually, so just recently. Really? The Australian Physiotherapy Association hosted our conference there. So we have a big clinical conference once a year, and then every other year it's like a leadership conference. We just had that in Hobart, and at the Hotel Grand Chancellor, and it was wonderful. Scott Morrison walked in when I was there. He's our Prime Minister for now. We changed them. We have single-use Prime Ministers. We change them like we change plastic bags.
I think it's your turn to be Prime Minister next week, isn't it?
Probably. Just tap me on the shoulder whenever I need to wake up from my nap. Wonderful that you change paths so quickly from, a lot of people have their sights on sports, I think, just because it's just what piques our interest initially, isn't it?
Glamorous, yeah.
Yeah, but then once you explore excuse my coffee, I'm still recovering from a cold. Once you explore the world of and the complexity of the older adult and physiology, especially, I'm sure just would steal your heart. With the eccentric, did you say eccentric? Eccentric
exercise,
I had a university lecturer who was fanatical about correcting people, and the fact that she corrected us on the pronunciation of that word has forever confused me and probably many others, and now we can never remember which one it is, because she was like eccentric, like it was this really long pronunciation. She was hilarious. Anyway, so eccentric strength is preserved in older adults to a greater extent than concentric strength. I have it in a slide for Level 1 Gerontology for Physiotherapy Association. Is it true, and do we have any idea as to why?
Well, it certainly seemed to be in this older population of masters athletes, and I think it is also true in the general older population. Now, why that is, I am not entirely sure, to be honest. But we certainly found that this bout of exercise they recovered from, as well as the young athletes. But what was interesting too was after they had the bout of exercise, which was just 30 minutes of downhill running, then when they repeated that exercise about 12 weeks later, for both the young and the older athletes, the recovery was much better. So we had quite a few refuse to come back for the second bout after they'd experienced the delayed onset muscle soreness of the first bout. But those that did come back reported over the next few days that the delayed onset muscle soreness was much, much lower or almost negligible. This is what they refer to as the repeated bout effect of eccentric exercise. And again, the actual physiology behind it, I think, is still unclear, or certainly was at that time, which is now going back about 10 years. So I probably need to brush up on where the literature is at on that at the moment.
Yeah, fair enough. Well, if you find it, I'm sure you will post it to Twitter. I'm just going to put it out there, at David Scott, PhD, goldmine on Twitter. I reckon I've probably retweeted your posts more than any other single person that I follow.
Yes, I appreciate it.
So moving on from there, so your PhD findings. So what was the topic of your PhD? It was about sarcopenia in community dwelling older adult population. So what exactly were you exploring there?
So, it's, I guess, another sort of shift of focus happened during the PhD. So we started the PhD, I think the topic was physical activity and sarcopenia in community dwelling older adults. But as we got into the PhD, and I kind of realised what a rich resource the TASOC study was in terms of all the measurements that were being collected, I found myself being pulled in several different directions of things that I was interested in looking at. So by the end of it, it really became a focus on the lifestyle determinants of sarcopenia in older adults. And so throughout the PhD, we looked not just at physical activity, but also nutrition and particularly vitamin D. We looked at statin therapy as well and how that might relate to progression of sarcopenia. and also looked at relationships with osteoarthritis as well. So it kind of covered quite a few areas, all with sarcopenia as the main focus as the outcome, but just, I guess, with an interest in understanding how these different lifestyle factors might be driving the progression of muscle wasting and strength loss in older adults.
Wow, that's really interesting. Statin therapy interests me particularly, and I've probably shared this with you over the years as well, because I'm on statin therapy. So I'm interested. Have I not told you that?
No, I wasn't aware.
Yeah, so I am a much older person inside a younger person's body, I reckon, because I've got osteopenia, and I've got I'll get a little bit of reflux too, and I take 80 milligrams of Lipitor, so atorvastatin, and I have been on that since I was 19, when I sort of just incidentally I fainted, and they wanted to know why, and I think it was because I was just freaked out in a lab at uni. But when they did bloods, they found that my cholesterol was really high. We have different measures of cholesterol in the US and Australia, so that for our US audience, I can't convert because like the calculation is not an easy moving a decimal point. But my cholesterol is like my LDL is 10.6, something like that, uncontrolled, so crazy high. And so we found that my family actually has familial hypercholesterolemia, so our livers just produce crazy amounts of cholesterol. So I'm the compliant one in the family who does the statin therapy. The others are a bit harder to convince of its merits, and I think a lot of people get scared away by the unknowns of statins, and it gets a bad rap. But tell me, if I've read a little bit here and there about statins potentially making it harder to put on muscle mass. Do you know anything about that? Just going off topic.
It's very much a controversial area, I think. So our study, this was back in, I think, 2009, was really. There'd been a lot of, I guess, case reports at that stage. People who started taking statins reported feeling muscle soreness and muscle weakness. And so we were interested in saying, well, if you looked within the wider community dwelling population, which we knew there would be a large proportion, I think we had about 25% of our older adults were on statins. And then looked at how their muscle mass and function kind of progressed over the following 3 years. Would we see anything? And we did find that the muscle strength seemed to decline in those that were on statins throughout the 3-year period, and then almost a nice little signal of a reversal for the very few, admittedly, who actually stopped taking statins. There seemed to be a bit of a rebound in their muscle strength. So that study got a lot of attention at that time, because obviously, again, a lot of people taking statins, a lot of anecdotal evidence that there was an association with muscle weakness, and here was some evidence to support that. However, since then, there's been quite a lot of studies that have really reported differing results. So in a lot of cases, finding no association, in some cases finding the opposite association, where people who take statins have better physical performance. And there has been now, I think, at least 1 or 2 randomised clinical trials where they've actually given statin-naive patients a statin and compared their changes in physical function. And those randomised trials, to my knowledge, really didn't show a negative effect of the statin use. So we're not exactly sure what it was about our study that showed an effect there. It may be related to the fact, of course, that the study wasn't really designed to look at this thing. So potentially we've maybe picked something up that wasn't there. The self-report of the medications and things like that could explain that. The only other thing, I guess, that maybe I sort of feel might play a role is whether statins maybe have a negative effect on your discrete muscle strength. So if you do like a discrete knee extension strength test, maybe there's a negative effect there. But the overall kind of cardiovascular benefit might actually override that in a physical performance test, such as a timed up and go test or a gait walking test, which is what a lot of these other studies have shown. It's usually the physical performance tests that people are performing better in. So yeah, my little theory is that perhaps there is a very small negative effect on the force producing capacity of the muscle, but maybe that is overridden to some extent by all the other kind of cardiovascular benefits.
I wonder how those cardiovascular benefits would hold true in a younger person. Like, my calcification score is 0, my heart scans and stuff like that. So I wonder if I can leverage any cardiovascular benefits from statins altogether. I doubt it, but yeah.
That's an interesting point. I think about our study is it's called the Tasmanian older adult cohort, but actually it was a relatively young older adult population. In fact, the criteria for entry were 50 years and 50 to 80 years. So the mean age of the cohort was only 62. So that's another thing that, I mean, as you point out, that if you're already relatively healthy, maybe the statins have a net kind of negative effect. But if you're that bit older in maybe the mid-70s to 80s, then there's a net kind of benefit because you're already functionally worse at that stage. So that was another kind of thing that we've thought about, as well as whether maybe in this middle-aged population, perhaps the effects on muscle function are negative, and maybe as you get older, the benefits might override that.
Yeah, that's interesting. Well, I can't conclusively blame statins for my disappointing body muscle mass. I'd like to, but I don't think I can. So I'll just...
Interestingly, we actually showed, despite the decrease in muscle function, there seemed to be an increase in muscle mass, and we really...
Oh, you're killing me, David. Yeah. No.
So that was another very strange association that we couldn't really make sense of. Now, we measured muscle mass using dual energy X-ray absorptiometry, DEXA, which doesn't allow you to see the muscle compartment in detail. So one of the things we suggested, which is an area of interest of my research, is whether there's some effect on intramuscular fat that I guess would make the overall muscle mass look larger, but the actual muscle quality would be poorer. But again, there's really no evidence at the moment to support or deny that theory.
Interesting. If you were to go on and do a study looking at intramuscular fat and look at measuring muscle mass in another way, how would you do it? Because how is it better to measure muscle mass than a DEXA scan? What's the approach?
So yeah, there's certainly, actually, I'm noticing it more and more at the moment. There's kind of a lot of negativity around DEXA for measures of muscle mass, and we should clarify we're actually measuring lean mass when we're using DEXA. So it's other obviously tissue types that are incorporated into your muscle mass that you kind of calculate from DEXA. So that's part of the reason that people at the moment are kind of less keen on DEXA. But the reason we use DEXA is because it's so widely available, and we know it's very, very precise in terms of its measurements. So the gold standard, I guess, would be MRI and CT. There's a really interesting method of creatine excretion that is starting to get more use, but really in the research setting only. But that seems to be quite a useful measurement as well. There's certainly a few different ways. You can use bioelectrical impedance analysis, which is you've probably seen those with a lot of bathroom scales now. Will give you an estimate of body fat, and that just works in that way. Now you can get machines that are a lot more accurate than the typical $100 bathroom scales. and the bioelectrical impedance analysis is useful given that it's quite portable, but it has questionable reliability. Things like hydration status and things like that quite heavily influence it. So I think in the research setting, certainly the CT, MRI, and now this creatine excretion method are certainly the ways forward. And certainly the CT is the method we use to look at intramuscular fat. But I think in the clinical setting, you'll probably continue to use your DEXA and I guess even your skin fold tests and the more easily available measures for the foreseeable future.
So, like as you can tell there, my dear audience, he is a wealth of knowledge. Thank you very much for that. I'm gonna pick your brain a bit about more clinically relevant measures of strength,
Sure.
Particularly what you've found around grip strength, because to me it's the canary in the coal mine. When we see a decline in grip strength, it can be a sort of a cardinal sign of early decline or even more advanced decline in other areas, of the human physiology. And particularly an article of yours, an article that you co-authored. I'm trying to look up the name of it right now, because you co-authored it with Seliu Balogun. He's a physiotherapist who I think initially he's from Nigeria. Am I right?
That's right. Yeah.
Yeah. And just a great brain who I met at a couple of conferences in the past. And Seliu I was actually in Tassie a couple of years ago I was presenting at the Tasmanian Allied Health Conference, and Seliu had a poster there about the association between osteopenia, osteosarcopenia. I think I might have my definitions wrong.
No,
Dynapenia and
osteosarcopenia and osteodynapenia. Yeah.
Yeah, and how of all of it was really, really interesting, and hopefully you might be able to remember a little bit more detail about the findings of that study. But the thing that I came away from it with was, wow, grip strength. Correct me if I'm wrong, but grip strength is a better predictor of fracture risk than, well, from this study anyway, and maybe it needs to be replicated, but it was a better predictor of fracture risk than a DEXA scan. Am I right?
Yeah, the combination of the DEXA scan and grip strength. So osteo, now we're really going down a rabbit hole on all these different terms and definitions of things. So forgive me, but osteosarcopenia is a relatively new term, and really what it's really meant to identify is people who have both low bone mineral density and also the presence of sarcopenia. Now, sarcopenia was originally defined as low muscle mass in the late 1980s. And for about 20 years, we kind of worked with that definition. But as we were working with it, we kind of realized that low muscle mass itself is not a very good predictor of functional outcomes. The things that we think of when we think of sarcopenia, people falling, becoming more disabled, being institutionalized and hospitalized, low muscle mass doesn't predict that particularly well. So in about 2008, a group of researchers suggested that maybe we've been looking at the wrong thing for the last 20 years. Maybe we should really not worry about muscle mass and we should think about muscle strength. And so they proposed the term dynapenia to address this idea of low muscle strength per se. Now, what's happened since then is really that term dynapenia is probably not progressed too far forward because the term sarcopenia through a few different consensus expert groups redefined to include both low muscle mass and low muscle strength. So at the moment, that's where we stand with sarcopenia. It is both low muscle mass and poor muscle function. However, some people are still looking at sarcopenia itself as low muscle mass and dynapenia itself as low muscle strength. And so what Salou did show in this study, as you rightly pointed out, was if you had low bone mineral density with low lean mass, there was really no increase in your risk of fracture compared to people who had normal bone mass and normal muscle mass. However, if you had low bone mass with low muscle strength, so osteodynapenia, then the likelihood of a fracture was increased by about 2 times compared to the healthy population. There's a lot of controversy, I guess, at the moment over osteosarcopenia. We recently published a paper that from the Concord Health and Ageing in Men project, which showed, at least in these older men who live in Sydney, Australia, the likelihood of fractures and falls was not really increased as a result of having both low bone mass and sarcopenia, which in this case we looked at both low muscle mass and muscle function. And it just seemed to be that really the osteoporosis component really predicts the risk of fractures, and the sarcopenia component predicts the risk of falls, but the combination of the two doesn't really multiply the risk in either. And that's what we found, but then other studies have shown different. And I think it's really just a reflection of different populations, but mainly the different definitions that everybody's using. And that's a real issue at the moment, I think, in terms of this field, is that we tend to be working with quite a few different definitions.
Yeah, we tend to be working with quite a few definitions of frailty as well, and cutoff scores for grip strength. What's your go-to resource for cutoff scores for grip strength to predict frailty? Like, do you go through a Z-score calculator or?
Yeah, so we've typically used the European Working Group on Sarcopenia definition, which is using the JMR hydraulic dynamometer, a hand grip dynamometer, which is important to recognise. That's the standard equipment used, but obviously if you didn't use that device, the cut points wouldn't actually be applicable to that device. So using that device, a hand grip strength score of less than 30 kilograms in men or less than 20 kilograms in women is what the European Working Group on Sarcopenia recommended back in 2010. However, just last week, the European Working Group came out with an updated definition of sarcopenia and revised criteria. And they've actually revised down those hand grip strength cut points. So it's now, I believe, less than 27 kilograms in men and less than 16 kilograms in women. So they're the cut points we tend to go to. Recently, I was part of a task force with the Australian New Zealand Sarcopenia and Frailty Research Society, and we, given all the different definitions of sarcopenia around the world, and particularly the main two are the European Working Group and the US Foundations for the National Institutes of Health. They're the main two definitions being used. We actually got a group of experts together and essentially did what's called a Delphi process, where we discussed, the issues at hand in terms of a sarcopenia definition and where all our preferences and thoughts were in terms of what is appropriate for the Australian and New Zealand populations. And as a result of that, we've just published a paper which states that our society recognises the European definition as being most appropriate for the Australian population. So that is the definition that we're typically using.
Okay, that's an interesting update. So I was using 20 and 30 as well. So just give us those figures again.
I can double check, but yes, it was less than 27 kilos in men, mm-hmm. and less than 16 in women.
Okay, great. Yeah. Would you mind this week tweeting that European updated paper, that would be really wonderful. And I'll tag at Senior Rehab, and Senior Rehab Project will be able to forward it on as well. It's frustrating, isn't it? Because I think, like, I like to use Fried's Frailty Index, and I believe that one of those 5 parameters is grip strength, obviously, and the definition for that is that it's got to be grip strength that is in the lower 20 percentile. Like, so you have to actually look at
your population,
Z-score population, and there is a really handy online Z-score calculator as well for grip strength, which I use, but it's annoying because I don't have. It just makes that little bit of an extra step that you've got to do clinically to calculate it.
That's right. And just another point, so the European Working Group in this new definition, it's actually changed quite a few important points, but something that they added as a muscle strength measure was the chair stands test, so where you get your patient to rise from the chair 5 times without using their arms. And so if they're unable to do that, or it takes them more than 15 seconds, to do the 5 rises from the chair, then that can also be considered to be low strength, which I kind of applaud that. Whilst I agree hand grip strength is a really useful measurement, I'm quite interested in looking more at the lower limb muscle function measures where I can, because I think they're going to tend to be more closely related with the mobility disability and the risk of falls that is kind of a key outcome for our research.
Yeah, for sure. And there's another gripe I have with the literature is that some people, like some studies, big studies, will use 5 times sit to stand, and then others will use the 30-second sit to stand test. And so you're like, which one? If I'm going to have this as part of my my clinical assessment tool for pretty much everyone that comes through the door, my basic set of outcome measures, and then after that you're going to choose ones that are more relevant to a presentation. But I have gone between 5 times sit to stand and 30 seconds sit to stand, so multiple times in my practice.
Sure.
We're on 5 times sit to stand again at the moment, but the trend changes according to I'll read a new paper and go, now we've really got to do 30 seconds sit to stand because that measure predicts this, or it is frustrating.
That's right. And look, I think we're really seeing an issue as well with, obviously these cut points are obtained in a scientific way through cohort studies, but it really, what strikes me is how much variability there is across the world in terms of people's muscle mass and muscle strength and what is normal. And certainly these cut points that have been proposed by the European group, I'm finding in my own Australian studies and a Swedish study that I'm working on as well, they're not really they're probably not applicable to those populations. What we're seeing is extremely low prevalence of sarcopenia in people that you kind of know do have sarcopenia when you use these cut points. So another task that we've set ourselves as the Australian New Zealand Society for Sarcopenia and Frailty Research is to actually, whilst we will apply the European measurements in terms of what they recommend should be measured, we're now looking within Australian cohorts to see if we can really nail down what's the right criteria for Australia. And I think you'll find that a lot of different groups around the world are sort of following similar processes, that understanding, particularly, in Asian populations, they have lower muscle mass and lower strength generally than Caucasian populations. So these cut points, whilst the overall algorithm for doing the diagnosis is sound, the cut points might not necessarily be applicable to all populations.
Sure. And just how my cough is just really ruining our interview, isn't it? Sorry. Just how people even measure a 5 times sit to stand, like that's going to vary a lot clinically. The chair height's going to vary a lot, but also whether or not, we were talking about this in the Senior Rehab Project group recently, like whether or not you've got to return to sitting to the point where your back actually touches the chair, the back of the chair every time, or if it's just a matter that your whole bottom has to touch the chair every time in order for that repetition to be counted. The difference is like massive. In
That's right.
What do you suggest for that?
Yeah, so we do it that they have to return to the chair, and we do have a set seat height, which I can't recall right now. I'm sorry, but
I reckon it might be 47 inches. I think I see that all the time.
Yeah, that sounds right. We definitely took sort of the one that was the most consistent in the literature. So yeah, we try to follow those protocols as best as possible. This new paper from the European Working Group, I noticed, I haven't looked at them in detail, but actually provides videos for each test for the practical instruction. So you can actually go through this paper and click on the links and see instructions on how to perform each test. And I think that's really important because the consistency between different the way that people do the different tests, as you say, is such a major factor, and particularly with physical performance tests. Coming from a sports science background, when we used to do our practical assessments in undergraduate, and we were taught to just scream at the participant when they're doing a maximal effort to get the most out of them. But in other countries, that's not what's done, and that can really have a big effect on what the maximal contraction that the participant can actually provide it can be. So certainly I think developing consistent protocols across the world is going to be really helpful for harmonizing all these measurements and cut points.
It's funny you should say that, because I was at the University of Queensland the other day just working on a little research project, and in another room there was someone yelling, like, go, 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 like yelling at the top of his voice. And I was like, oh, what's that? And the researcher just rolled her eyes and she's like, they're looking at maximum voluntary contraction. So they scream like that all the time. And I thought, well, we don't really do that. It's interesting.
No. We don't tend to do it with my older patients when they're just doing a hand grip strength, but we'll usually give a fair bit of encouragement and ask them to, and if we feel that they're not giving us everything they've got, then we'll sort of ask them if maybe they're not giving us everything. But I mean, I certainly anecdotally know in other countries where culturally that's probably not appropriate to scream at an older adult, then that's not done, and that could certainly, I think, partially explain why certainly in some Asian countries you see such large differences in their maximal muscle strength compared to what we see in places like the US and Australia.
Yeah, I could see that. And before we move off the topic of grip strength, and I actually reckon I should probably do an entire interview with someone just on grip strength, because there's that much there in grip strength. Amazing. But just quickly, sitting or standing when you measure it, and best score or average of 3, because I keep reading different protocols all the time.
Sure. I can probably retweet a protocol that we use, which is there's a group in the University of Southampton in the UK that have really led the way, I think, on this protocol, and we do it sitting, and best of 3 attempts is what we use. But you're right. There is a lot of different methods used, but we try to follow this protocol of the UK group, which I can again tweet out the link to that paper.
Wonderful. When you do that, if you just don't have to do it today, but when you do, just tag at Senior Rehab and we'll forward it on as well. It would be great. All right. How about I stop throwing curveballs at you as well, and we start going into more depth about what it is that is your primary area of interest at the moment. You are doing some great work around sarcopenic obesity and the fall and fracture risk and frailty risk, I guess, of people with sarcopenic obesity. Would you mind defining sarcopenic obesity for us?
Sure. So this one is a bit like the osteosarcopenia definition, where you take a combination of two syndromes, I guess, and then look at whether the combined effect is perhaps worse than either one on its own. So sarcopenic obesity is the presence of sarcopenia in obese older adults. So the way we define that at the moment is using the European definition of sarcopenia. By this, it generally means you have low muscle strength with low lean mass and or low physical performance, so a poor gait speed time or a poor timed up and go time. And then obesity, we don't really like to use BMI in older adults where we can avoid it. So luckily, being in a research environment and having access to DEXA, we will use DEXA to look at the participant's body fat percentage. And for men, if their body fat percentage is greater than 30%, and for women, if it's greater than 40%, we classify them as being obese. And then the sarcopenic obese people are just the people who have both the sarcopenia and the obesity.
Right, and what is special about that population that interests you?
Well, I think it's really interesting. As we talked about earlier, I think we sometimes see a bigger older adult, maybe not necessarily what we think outwardly as being obese, but we can look at them and say, they look quite big and solid. They must be quite robust, but really we don't know what's actually making up that body shape. And a lot of the time they could have quite low muscle mass and quite high body fat. We know that muscle mass obviously goes down with age and body fat goes up with age. And so outwardly they might look quite good, but inwardly maybe not so much. And really, I think the key thing with sarcopenic obesity, which is why I think it's such an important issue, is if your muscle mass is too low to move the body size that you have, particularly when you've got high body fat, then you're going to have mobility issues and all sorts of other issues, I guess, in terms of your physical function. The other thing we know with obesity is that it in itself is a strong predictor of falls risk. Obese people tend to fall more often than non-obese. And something that we've been really interested in, I guess, is also how it influences fracture risk. Again, historically, we've thought, okay, obese people, they're protected from fractures. And that is true to an extent because they have higher bone mineral density. And also they get a little bit of a shock absorption effect if they do fall because of the extra padding that they have around the hip. And so hip fractures are definitely lower in the obese population, but you see other types of fractures can be much higher, such as lower leg and ankle type fractures. So I was really interested in this population to look at, I guess, to challenge that perception that perhaps permeates a little bit with clinicians, and I don't think it's a kind of bias that they really that's a bias of theirs, but it's maybe just a perception that they have that maybe with their obese patients they don't have to worry that these people are going to have fractures. So what we did in the Concord Health and Aging in Men project was look at whether there was a difference between men who were obese and men who were sarcopenic obese in terms of their fracture risk. And we did indeed find that if you are just obese without sarcopenia, you're protected from fractures. But if you have sarcopenic obesity, you've got about a 2 or 3 fold increased risk of having a fracture. And I guess the scary thing about this is, if we look at some of the DEXA images of these people, in terms of the outline of their body shape, you really wouldn't know the difference between them. There's no clear way of knowing that just from looking at them. But then when you actually look at the lean mass and the fat mass, you can see these differences. And you can also see differences in their bone density. The sarcopenic obese people have much lower bone density, which is probably contributing to their fracture risk also. And certainly falls are contributing to that fracture risk because they also had increased risk of falls. So I guess, the overall message that we've taken from that, and now we're following on with clinical trials in this population specifically, is this is a population of obese older adults that aren't protected from fractures, and they need to be considered for interventions which can improve their bone health and also allow them to improve their physical function.
Yeah, right. It hits home for me particularly because that's my mum in a nutshell. Like, she is definitely sarcopenic obese, and she lives in Melbourne. So if you need to recruit anyone to your studies, just I can hit her up. But yeah, I mean, yeah. Well, I certainly see, like, with her, I've seen her balance has been poor for a long time, and she's not particularly interested in changing her lifestyle. I won't ever win that battle with her. But I've been the only person that's been really worried about it, and I actually had the chance. I went with her to a doctor's appointment about something else several years earlier, and I said to the doctor, I am really worried about her fall risk. I'm really worried about her fracture risk because I've got low bone mineral density, and I know that 75% is genetic and 25% is lifestyle. And I was definitely deprived of, not deprived, but I didn't have a great nutrition and didn't have great calcium intake as a kid in particular. But I thought, well, mum's had the same diet that I had growing up and has the same genes. And so I asked for them to do a bone mineral density scan, and what do you know? They found she was osteopenic, almost osteoporotic at the time. But the doctor's opinion of it was, doesn't matter. She's got padding. That's the silver lining, isn't it? And I kind of took a little bit of reassurance from that as well, and I shouldn't have, and I still nagged her about balance and etc. and gave her my balance book, and left it next to the kettle several times trying to get her to do it. But if only she had listened. But even again, this time she fractured in both arms, and I went to hospital with her, and the doctors again were sort of not so worried about the fall risk side of things because of her size. They assume she is robust, and I actually said, this is sarcopenic obesity sitting in front of you right here. You've got to think about this physiologically. This woman is declining at a much greater, a more advanced rate than we would expect of her age in her early 60s. And they sort of just looked at me like, what are you talking about? It wasn't. So I think you're being very careful there with not offending me as a clinician about bias, but we do have that bias. We do have, I think there are a huge number of people that are missed because they look robust because they're overweight.
That's right. And so, I think, in defense of clinicians as well, the evidence is there that really maybe we should be avoiding weight loss in our older adults. You hear about this obesity paradox across so many different conditions where once you get to a certain age, the 60s and 70s, the more obese people are the people that survive and generally have better outcomes. But something that we've really been, I guess, trying to drive home about that is all this evidence is based on obesity assessed by body mass index. And we know that the body mass index is actually not a good predictor of obesity. It's a good predictor of lean mass. So what you're actually showing, we think, is that the people with more lean mass are having better outcomes. And we've just been working on a study that is still in preparation, again in the Concord Health and Aging in Men project. And with this one, I was really interested to drive this point home. And so what we did was we looked at men who either lost 5% of lean mass or more, or 5% of fat mass or more over 2 years, which 5% is kind of an arbitrary amount of weight loss that's kind of considered to be clinically significant. And then after that 2-year period in which we looked at their body composition changes, we then followed up to see, okay, so what was the outcomes for their bone mineral density, their physical function, and their falls and fractures? And what we actually saw was that losing fat mass really had no negative effect on any of those outcomes. So if you lost fat mass, you didn't lose more bone mineral density, you didn't get worse with your gait speed, you didn't have more falls, you didn't have more fractures. If you lost lean mass, then you had an issue. So something that we're now, I guess, concluding from that paper is that, weight loss is safe for obese older adults, but we need to incorporate exercise to ensure that we're maintaining lean mass as much as possible. And so that's really a couple of the clinical trials that we're working on at the moment is looking to explore that further.
Yeah, and I imagine part and parcel with that is also nutrition. So with any exercise regimen to reduce obesity in an older person or to improve lean muscle mass, diet is going to be a factor, and it's a factor that sometimes it's hard for us to address because we're not part of a team where there is a dietitian or a nutritionist, and we don't have necessarily access to funding for a consult for that person, and we sort of feel limited in our understanding of it or in our scope of practice and not able to or don't feel that we are in the right position to advise anybody on diet. I know that you've looked a little bit at diet and supplementation and protein and that sort of thing. And I know Christina Privet has previously, for the Senior Rehab Project podcast, or perhaps for our sister podcast, the Stave Off podcast, talked about a protein and protein recommendations for the older adult and how that seems to be shifting with every new study that comes out. It seems to be like, oh no, more protein is safe and more protein is good. What's your position on that, David? Do you have one?
Yeah, I mean, again, like yourself, not a dietitian, and so I always defer to the experts, but certainly the research that I've read, and you read people like Stuart Phillips and other researchers in the protein space, and it gives me a lot of confidence that actually our protein recommendations for older adults are too low, and we should be increasing them. I think certainly our standard now is that we recommend about 1.2 grams per kilogram per day of protein, but evenly distributed across 3 meals. So trying to get about 0.4 grams per kilogram at each meal across the day, breakfast, lunch, and dinner. And I think there's really good evidence now that is safe, but also effective in terms of at least maintaining muscle for those who aren't exercising and maybe augmenting the exercise effect for those who are exercising. So at the moment, with one of our studies in sarcopenic obese older adults, we're giving all of them a weight loss intervention, and then we're giving half of them an exercise intervention targeted at maintaining the bone health. I guess to show what I mentioned about whether we can really ameliorate those declines in lean and bone mass that occur in weight loss in obese older adults. And as part of that, we're giving them 1.2 grams per kilogram per day of protein across the day.
Oh yeah, right. That's interesting. So 1.2 kilograms across the day. Okay. And then potentially upwards from that in the future? Do you think
Yeah, look, I think there's certainly some researchers who think much higher is safer. I've heard as high as 2 grams per kilograms per day. Myself, again, I guess not being an expert in the area, I tend to be a bit more reluctant to push the limits too high. And I think the evidence that I've read seems to be around that 1.2 to maybe 1.4 mark is where the benefit is at. So, but I can certainly see it potentially, certainly for those who are exercising, that the recommendation could get much higher, up to even, 1.6, that kind of region.
Yeah. What would be the risk of having a higher protein intake than that? Like what, we sort of worry about an upper limit there. Certainly with calcium, you don't want to prescribe too much calcium because there are effects on the cardiovascular system or the circulatory system. What would be the concern about somebody having too much protein?
Yeah, the main concern is around renal issues. Again, it's not exactly my area in terms of what the mechanisms are that drive that, but there's been I think concerns about
excretion and
exactly, overconsumption of protein, having severe kind of renal issues. But I think from the evidence, it has to be extremely high levels of protein really to really run that risk. So certainly I know a lot of the experts in the field think that risk has been wildly overstated.
Right. I mean, you never know until you have these really big RCTs, do you? People were all for mega doses of vitamin D, yearly or half yearly in vulnerable older adult populations or institutionalised settings, and then we had 2 big RCTs that showed that for some reason unknown to us really, that those mega doses of vitamin D increased falls risk, and that everyone backed off from that, and now it's just down to daily or weekly doses for vitamin D. And I know vitamin D is not your I know you've done a little bit you're a bit interested in it, but it's not your key area of topic of research. Sorry, but it's a bit of a mystery, and I don't know that you've got the answers either. But vitamin D and the mechanisms that might influence falls. I mean, it's sort of proposed that it would have a mechanism on the muscle, because we know that we now know, I think that's a fairly new discovery, is it, that muscles have vitamin D receptors, just like nerve tissue has vitamin D receptors?
Sure, yeah. It's been a bit of a bit of a back and forth discovery in some ways. I remember, I think it was maybe the early 2000s that a vitamin D receptor was reported in muscle, and then that was challenged sort of more recently, probably more around 2010, that maybe this was not correct. But I think the current understanding is that no, there is a vitamin D receptor in human skeletal muscle, and that may be the mechanism that vitamin D has an effect on muscle in terms of improving in protein synthesis in the muscle. So that seems to be the main effect potentially with falls, or is at least hypothesized to be. I think the other thing is around cognition, because there's some evidence of benefits on cognition, which obviously plays a big role in falls. And then also the anti-inflammatory effect of vitamin D. If there's some sort of anti-inflammatory effect that can improve our muscle function also. Certainly it's as vitamin D has lost a lot of its luster in the last few years. I think we probably 10 years ago thought it was nearly a cure-all for all the world's ills, and now it is certainly looked on with a fair bit of skepticism, I know, amongst a lot of researchers and clinicians. And I guess it's just a virtue of the fact that we've seen so many observational studies where participants who have better vitamin D status have better health in a range of outcomes, from skeletal to musculoskeletal system to even the non-musculoskeletal systems. But then any clinical trial, really, there's very, very few clinical trials, to my knowledge, that have really shown any benefit of vitamin D supplementation. It doesn't seem to have much of a benefit. Now, part of this might be related to the fact that a lot of these trials have given vitamin D supplements to people who already have adequate vitamin D levels, and I think that's been a big issue with a lot of the studies. There was a recent study from New Zealand that I think shed some important light on this, which showed no real effect of vitamin D on bone health in the wider population. But when they kind of narrowed down their focus on certain subsets, they found there was an effect for people who were below 30 nanomoles per litre of 25-hydroxyvitamin D. So this is where in the range that we would call insufficient to deficient. And so that might be going forward where there is some benefit, but certainly at the moment the evidence is really not there for maybe what we were saying 10 years ago, which is, well, vitamin D supplementation should just be ubiquitous. Everybody should be taking a vitamin D supplement. I think at the moment there's just no real evidence for that.
Yeah, it's I think we're still a little bit confused, aren't we, about exactly the right doses and whether it's necessary whatsoever. I was saying to you before we started recording this that I'm actually quite lucky to have one of my long-term clients. She's a client who's just interested in healthy aging. Associate Professor Rachel Neal at the Queensland Institute of Medical Research. She's doing an HMRC-funded study on 25,000 Australians aged 60 to 84 to try to determine basically whether or not vitamin D impacts health conditions like cancer and heart disease and infections like the flu, and how much we need it. I think Rachel might be the first client or patient of mine that I interview on the podcast when those results come in, because I think she's expecting her results early next year. So watch that space with recruiting 25,000 participants. We might have a little bit more of an understanding about the role of vitamin D in preventative health as well, which would be really interesting.
There's a couple of big studies in Europe and the US, I believe, at the moment that are very close to publishing as well. So certainly one that looked at vitamin D with omega-3 as a study in older adults, and some of that data I think that will come out over the next year or two is probably going to give us a much greater understanding of what we should be doing in regard.
Oh,
you still got me?
Oh, I just lost you for a little moment, but that's all right. So do you want to just repeat that part again so I can edit it really nicely, just where you began talking about the studies that are expected to come out soon? Yeah,
so there's a couple of other large studies in the US and Europe which are close to finishing, I think, as well at the moment. There was one in Europe which was looking at vitamin D and omega-3 as a combined supplement. And so some of the data that will come out from that, as well as these Australian studies, I think is really going to clarify for us what we should be doing with vitamin D going forward.
Definitely. I think that's probably a whole podcast episode in itself, maybe to be done next year. I think I've got some notes on vitamin D in my little Trello account right here, and here's a few key points for the listeners just to spark your interest. People with vitamin D deficiency have less muscle mass, have reduced lower limb strength, slower, simple and choice reactive stepping times, poorer leaning balance, slower gait speed, poorer executive function and visuospatial ability. They are just points that I've written down over the years. Definitely worth us nutting out how accurate they are and what the mechanisms might be at play there. David, I want to be respectful of your time, and you've probably got to get to work. Is there anything more that you feel you'd like to share with me or with our audience about your research? Any key clinical pearls that we can take away from it, or watch this space flag for future studies that you're involved in?
Sure. Yeah. No, I think definitely a watch this space flag for a couple of our clinical trials that we're running in the obese patients at the moment that I mentioned. So our weight loss study for sarcopenic obesity, incorporating this exercise program that you might be familiar with, the Lift More program that Belinda Beck in Queensland has developed, which is a really bone-focused exercise program involving overhead
press, deadlifts, lunges, jumps,
and drop jumps. That's right. And so what we're hoping with that, Belinda's shown that to be really effective for postmenopausal women with osteopenia and osteoporosis in terms of improving their bone health. And what we're hoping to show is that the same program can offset the weight loss associated decline in bone mineral density and bone structure in obese older adults. So that one's recruiting at the moment. It's underway. So keep an eye out over the next year or two for those results, because we're really, I think, excited to venture more into this space of giving clinicians reassurance that they can give weight loss to their programs to their obese older adults, and as long as they're ensuring that they're completing exercises that stimulate the muscle and the bone, then there's going to be a lot of benefit for that patient, and hopefully no negative effects.
Yeah, absolutely. Oh, I'm so excited that, because just before when you were talking about that trial, I didn't want to interrupt you, but I had actually flagged in my mind asking what the exercise intervention is. I hope it's Lift More. And so great that you are doing that. And I should actually make a correction there, because in my excitement I actually said that wrong. The exercise intervention for Lift More is overhead press, deadlifts, drop downs, jumps and loaded squats, not lunges. Right. But yeah, that's certainly what I try to implement in my practice when I can convince an older adult or anyone at all at any age actually to get into the heavier weights and a more structured regimen is I base it more on the Lift More trial, even perhaps which is a little bit more heavy loading, lower reps and higher weights than the ESSA guidelines, the Exercise Science Australia guidelines on exercise for bone mineral density. I sort of think they might be even slightly more conservative than they need to be. And Belinda Beck runs a clinic around the corner from me, and
you'd be very close there.
Yeah, like literally I can almost see her clinic from the gym that I run exercise classes in. So I have sent a couple of patients over to her, and first I've got to tell you that it's hard to get patients to do it. I have recommended it to far more of my patients than have actually followed through.
Sure.
And I have sent a couple who have come away saying no as well. They've just gone, no, not for me. So we do have to have alternative models, because as much as we want to promote, the value of deadlifts and loaded squats and that sort of thing, we have to appreciate that compliance is not great with that style of exercise at this point. But this is an N=1 takeaway from the Lift More kind of protocol. I know that study actually was an 8-month intervention, but I have a patient. We're only talking about one patient, so and I don't know that it's fair to generalize. I'm sure it's not, but I have a patient who I sent over to her clinic, and I'm pulling up this patient's DEXA scan results right now, because this was amazing. After 15-month intervention, she improved her bone mineral density in the vertebrae by 14.8%, David, and in the hip by 9.5%. And that is unheard of. I mean, I think
fantastic, yeah.
Liftmore was an 8-month trial where I think the average bone mineral density increase was around 3.8%, something like that.
Yeah.
Is that about right? Estimate. But yeah, 15-month intervention. This is sample size of one. This is my one patient that I've sent there who has stuck with the program long enough to do, the follow-up DEXA, and those were her results. And this is a patient who I have invited onto the podcast to talk about her experience, and she's very reluctant. But she, she's improved her diet as well, and went through all of the advice at this bone clinic around the corner. And she met with a dietitian. She had advice about supplementing calcium and improving her diet, but she did not commence bisphosphonates. Against my advice, I strongly encouraged her to take bisphosphonate therapy as well as the exercise and diet intervention, and she hasn't, and she managed to turn around results like that, so she proved me wrong.
Yeah, I mean, that's outstanding. And I mean, you're exactly right in what you say about, compliance and willingness for patients to pick up this type of exercise. And we expect we're going to experience even greater challenges, given that we're trying to do this with obese older adults who are probably people who, for most of their lives, have not enjoyed exercise and certainly not exercise that's performed at such high intensity. So, yeah, we're expecting it to be a rather slow process with recruitment and quite challenging to retain them. But I think if we can show these benefits, and if we can get benefits like that, then we might be able to encourage a few more to get involved.
Yeah, definitely. I think if we can show the benefits over a prolonged period of time, even an 8-month intervention in my mind now is like, well, that's obviously not enough to show the true benefits. Well, this particular client might have been an exception to the rule in terms of her results, but, I sell it every day to the other patients in my practice, and I point to her as as an example of someone who's improved so much with this kind of an intervention, and from that, another person has just had her first appointment at the bone clinic last week. So, from seeing one of her peers in our balance class do so well. So, yeah, I think that there's definitely more room for lifestyle and lifestyle research, or research around how to improve attitudes towards these type of interventions, and how to change fixed beliefs around heavy resistance exercise and what that can do for your body. Or there's just so much more to be done in that space. I'm so excited to be connected with people like yourself who are involved in it, so that we can find out this information when it comes hot off the press, and not wait 10 years for it to trickle down into practice.
Sure. And we as researchers rely on people like yourself to tell us when the great ideas we have are just actually not going to work in the real world. So it's very important that we have these ongoing conversations, I think.
Yeah, absolutely. I'll tell you, one thing that's not working in the real world is grip strength testing. It's not even working well in my practice because the JMAR dynamometer is such an expense. $600 Australian, so maybe 400 US. The weight of it to carry it into someone's home, physiotherapy or rehab is becoming more portable now. We're trying to get people out of hospitals earlier, get them into the home. We're trying to see and assess people in community venues and bring our services to the community. And that means we don't have a fixed station. We don't have that laboratory with a 47-inch chair all the time, so I think we need to be trying to validate or create or develop a smaller handheld dynamometer that maybe can just be cheaper but certainly more practical to carry around. I think that's going to...
Sure. I'm talking to engineers at Monash University at the moment about this very idea. I totally agree. I'm actually, as I've mentioned, I'm maybe more in favour of lower limb strength testing. So where we're discussing ways that we could actually be measuring knee extension strength, for instance, with some type of very portable device. Now, it's quite challenging, and I don't think we'll have anything for you to be using in the near future, but it's certainly something that myself and quite a few other researchers are cognizant of, that clinicians need something that's affordable but reliable and portable. So, we're working on that.
And, something that might be useful, it's just come to me now, and I don't know if it's really your field, but with 5 times sit to stand testing, I know there's so much normative data already there, but and you've said there is a bit more clarification in that European protocol, so I'm going to watch the videos to see exactly how they want it scored. But the chair height, it is a set chair height. I think it's 47 inches, but whatever it is, it's a set chair height, which you can't always get in someone's home. And then also you've got this problem where a really, really tall person is not going to perform as favourably as a short person who's got a mechanical advantage with that chair height. I really wish that we had a measure where the chair height was not dictated to us, but rather the hip and knee angles, like, eyeball 90 degrees at the hip. And voila, so that I can change the height by using cushions or changing the surface that the person's sitting on, rather than just be like, okay, well, this test isn't valid anyway because it's not the right height. Yeah,
definitely. I think there's, a lot of work to do with a lot of those physical performance measures. Even things like gait speed, with the course distance that we do them over. We know that if you do it over a really short course, you'll get lower values because people don't sort of get to their max speed before the course is almost over. So, there's so many of those things that we need to really, I think, almost get together as a research community across the world and just harmonise exactly how they should be done.
Yeah, absolutely. Well, I think if anyone's going to do it, it's you. So I charge you with that very important and onerous task of trying to harmonise those standards of physical performance measures, at least in our career lifetime, so that future generations after us don't have this battle.
Right. I'll add it to the list of things to do.
Yeah, I'm sure that list is growing. And on that note, I'm going to let you get on with addressing that list today. So thank you so much for your time, and it's been really wonderful to put a voice to the Twitter profile, and I'm sure that I'll continue to ask you many, many questions in future years on Twitter. And if you come up with anything that you think is of value to talk about with our community again in Senior Rehab Project, please just tap me on the shoulder. You've got a standing, open invitation anytime.
Thank you very much. Likewise, it was great to finally talk to you. I really appreciate your interest in the field. We need as many clinicians as possible interested in sarcopenia, because as researchers, that's what's going to really help us move the field forward. Having people like yourself collecting data, doing more in terms of treatment, and so we can understand what works best in the real world. So, more strength to your arm.
Thank you so much. All right, Senior Rehab Project. This is a wrap from me and from Dr. David Scott at David Scott PhD on Twitter. Until next time, stay funky.
Thank you for listening to the Senior Rehab Project. If you've gained from this episode, consider supporting our work. You can become a patron through Patreon, a service that allows people like you to support people like us. You can give as little as $1 a month or become a game changer for $8.99 a month. We'll get an awesome redefined old mug and access to all the special things we do monthly. Just go to seniorrehabproject.com to learn more and find the show notes for this episode. And remember, stay funky.